So good afternoon, everybody, and thank you for joining us in the next of our series of webinars from Ophthalmic Consultants of London. Thank you to everyone who has joined us for our previous webinars, and a welcome to everyone that's joining us today for the first time. These webinars are recorded, so they will be available to view later online on our YouTube channel, Ophthalmic Consultants of London, and that's where our previous webinars will be found as well. For today, there is one CET point available, and that's for optometrists, dispensing opticians and therapeutic optometrists. This lecture today will run for 45 minutes with questions and answers at the end. There is a Q&A box at the bottom of the screen, so throughout the lecture, if you have any questions, please pop them in that box and we will get through as many as we can at the end of the lecture. So today's speaker is Sally Ameen. Sally is a consultant ophthalmic surgeon with us at OCL. And also at London Imperial College Healthcare Trust. She is an expert in the management of all forms of glaucoma and a specialist eye surgeon that performs all glaucoma surgery, and is also highly trained in complex cataract surgery and emergency ophthalmology. Sally, over to you. Feel free to share your screen when you're ready.
Hi everybody, thank you for joining us this afternoon. If you just bear with me, we tried this out earlier and it worked just fine. So as Pavi kindly pointed out, the title of the talk today is Glaucoma in the current COVID-19 situation. So I'm Sally Ameen. I am a consultant glaucoma and cataract surgeon and part of the Ophthalmic Consultant of London team. And for my NHS practice, I work within Imperial NHS Trust. So the aims of today's talk is to talk about the real life changes that are happening on the ground right now for our glaucoma patients during the current coronavirus crisis and how everything is changing. How we've adapted on the ground. And the new Royal College of Ophthalmologists guidelines with relation to management of glaucoma patients and what we think the recovery might look like. So before all this started, if I cast your minds back, I'm sure everybody's aware that glaucoma is the leading cause of irreversible blindness. It is a chronic disease with an aging population, so many of our patients don't get discharged and do have regular follow-ups in the clinics. That leads to busy outpatient clinics, long waits for operations when they are required, and puts a lot of pressure on the current services, both NHS and private. So there's already been a movement to explore using different modes of delivering the service and the care to our patients that we think they deserve, and that's in the form of using virtual clinics, varying treatment options and modalities, and the use of drops that are more tolerable so the patients don't have to come into the clinics, or doing surgeries that are shorter and safer so the patient doesn't require too much post-op follow-ups, and the use of allied healthcare professionals in the form of our trained optometrist and nurse specialist within glaucoma. And then came COVID about, well, feels like a lifetime now, 6 to 8 weeks ago. As everybody else, we started planning how to deal with our emergency cases before the imminent lockdown was about to start. Where possible, we arranged face-to-face reviews for these patients after they've had any kind of surgery and agree an ongoing management plan for the foreseeable future. And everybody started thinking ahead about how over the following weeks or possibly months we're likely to manage these patients, what things on the ground are going to look like, and maximize the use of staffing. There was already in a number of hospitals within the NHS where the ophthalmologists were redeployed into other sites of the hospitals to help out with the overgrowing pressures because of the increased influx of patients to the hospitals, either secondary to COVID-19 or actually lack of staffing in those areas, and they required the support of our teams. So the main issues that we have on the ground now, we are in the crisis situation, the space in the clinics. I'm sure many of you have visited outpatient clinics across the country, whether it's in the private sector or the NHS sector. The clinics are not designed to respect the social distancing of 2 meters between patients. They are usually full with lots of people attending at the same time. The patient demographics, like we said, it's an aging disease with patients with lots of other comorbidities. They're at higher risk of getting COVID-19 or contracting it and becoming very unwell with it. Staffing issues, like I said, 2 reasons. Many of the junior staff and even the consultant staffs were redeployed to other areas within hospitals to help out in the current crisis, and there was staff sickness or self-isolation because of members of their family being unwell. A number of these hospitals, because of lack of staffing and resources, the ability to get the normal treatment modalities, whether it's surgical or laser or even sometimes drops, was restricted to both the patients and the doctors. So how have we adapted on the ground? So in the outpatient department, shielding of every patient, we reduce the length of stay of the patients when they do have to physically come into the clinic. Most of the patients now receive a telephone consultation, and this is when things like electronic patient records have become vital. The use of this has made it very easy to access the patient's records, look at any previous imaging they've had, any visual fields they've had, and be able to kind of formulate a plan even prior to speaking to the patients. Again, for many of us, these patients we've had for quite some time, we know what they have, and then can advise them on treatment accordingly. And also, because of the electronic patient records, we were able to maybe discuss, say for instance, they were having issues with some drops, that we can change the prescription and email it directly to the GP, and that gets updated onto their electronic records there and to the pharmacy without them physically having to come in to get an up-to-date prescription. For those that physically do have to come in, like I said, we reduce the length of patient pathway, so we are aware of how many patients will be coming on at any one particular time, and we make sure there's enough spacing for all those patients. If they require any further investigations, like for instance in the glaucoma patients, a disc OCT, then that gets done swiftly, and they see the nurse and the doctor very quickly afterwards. Wear appropriate PPE for those patients. For every single patient, I'll share a picture in a minute. We do have on the slit lamps shields to protect both the patients and ourselves. We wear masks, we wear gloves. The surfaces get wiped between patients, so that includes the entire of the slit lamp, the chair on which the patient sat, and anything that they might have come in contact with. Like I said, we maintain social distancing in the waiting area. So this is just a picture of the waiting area at the Western Eye at the moment. As you can see, it's empty, which is a miracle by itself for those who have had the pleasure of visiting our waiting area, but also the chairs have been spaced out to ensure if there is more than one patient in the waiting area at the same time, that there's enough spacing between them all. This is a picture of myself, and this is the gear that I was wearing at the time in clinic yesterday. So we wear a visor, a mask, an eye shield on top of it if you wish, but to be honest, the visor does the trick. Everybody is in scrubs that you change into when you first come into work and out of before you do leave work, and then gowns if you wish to wear them, and like I said, gloves and cleaning all the surfaces in between patients. So what's happening in the operating theatre? So again, the advice from the Royal College, covering both private and NHS sectors, essentially is only sight-saving surgery to go ahead. Now, as we said, glaucoma causes irreversible sight loss. So we have had a number of patients that have had to require operations during this period of time. And we have to factor in the availability of the operating theatres. So again, staffing issues, not just in terms of the surgeons, but in terms of the scrub nurses. Quite a few of them had to get redeployed, and an anaesthetic cover. So again, anaesthetists, as you know, a lot of them were redeployed into ICU, and rightly so. So there is limited space and access to the operating theatre itself. It's shared with other subspecialties, so mainly that will be vitreoretinal surgeries and any kind of trauma cases. So like I said, in the Western Eye and Imperial, because it's a big trauma centre, there we have seen an increase in number of the trauma cases. So it's planning ahead, and really only the stuff that you think needs to get done has to get done. The same rules apply in terms of OPD, or even more so in terms of patient safety, social distancing. Most of the ophthalmology procedures for glaucoma, so that's cataract surgery, trabs, tubes, or lasers, are not deemed aerosol generating procedures, but for instance, if the patient has to undergo general anaesthetic, that's something to keep in mind. There is an air exchange time between cases if required. So On a normal list, for a glaucoma list, if you're doing a couple of bigger cases that take over an hour and a couple of the smaller cases, you can get through 5 to 6 cases. At the moment, you'll be lucky to get through 4 cases for an entire day. So that'll be 2 sessions of theatre. And that's for obvious reasons, and everybody is very understanding of all that. So we've been trying to modify surgery to try and get as many patients in safely as possible. So where we can, make sure the operation's done under local anaesthetic, so safe for the patient and safe for the surgeon and the staff around, and perform shorter operations. And I'll show you examples of that in just a minute. So that's, again, less exposure at the time when they are in theatre. They tend to be safer, less risky if possible, and suitable for that patient, and require less follow-up. So it's not just the intraoperative period that we need to think about, but it's the post-op. Normally in the NHS we don't consider bilateral surgery, but at the current time, if you feel that the patient will need surgery to both eyes, consider doing them both done at the same time. So I wanted to show some example of some of the operations that we've been doing over the last few weeks while we're in lockdown. So again, it's mainly going to be focused on the glaucoma side of things. This gentleman, I'm not sure if you can appreciate from the photographs, essentially has uveitic glaucoma that's led to iris bomboia, with the iris being stuck down, and secondary glaucoma as well. He has a patent PI, and despite that, a maximum medical therapy in the form of drops and acetazolamide tablets, the pressure was still uncontrolled. And if you can have a look at the picture down here, you can see how you can appreciate how shallow that anterior chamber is. So after discussion with the patient, it was agreed that he will have to undergo cataract surgery. So just to show you a video of this, I'm sorry, me and technology are not the best of friends. It wasn't playing fair today, so I haven't been able to cut it short. So this is live, but I will pass through. If you can appreciate, so normal cataract, when you do the operation, the pupil is very well dilated. This patient, nothing was happening because the iris is stuck right against the capsule. So, and the anterior chamber, as you saw from the photo, was very shallow. So when the first blade goes in, it actually goes onto the body of the iris. We use viscoelastic to try and expand as much of that anterior chamber as possible, just to create a bit more space. And we use heavier viscoelastic than standard. And that's just with a bit of prayer, maybe there's a tiny bit more space. And you can see that if you can appreciate how the blade has left a dent in the iris tissue, but thankfully not cut through. And then again, just sweeping around, try and create a bit more space. And just here, so in this corner here, thankfully I've managed to create a tiny bit more space than elsewhere. And then you can appreciate when the blade goes in now, it's not touching on iris. So the first issue with this is, again, the operation was done under local anaesthetic, so we had to make sure they're as comfortable as they can be, because it was going to be longer than the average cataract surgery, but there was some movement. Now we're trying to break up some of these adhesions with the viscoelastic, but it's quite stuck down. So at this point, I normally use a blunt instrument like the spatula that you can see here, just to try and separate the tissues and create a plane between the iris and the capsule underneath without causing any damage to the capsule where possible. I'm just going to try and speed up this for you, because there's a couple of videos. So even after breaking up all the synuclei, the pupil margin is still very small and the access to the capsule is restricted. So these little things that you can see, these are iris hooks. I don't know if many of you have seen these before, and they're like little clips that go into the iris sphincter and just hold the iris out of the way. They're quite thin and small, but very handy. Again, it's a tight space, but thankfully going in quite nicely. I normally put in 4 hooks. Different surgeons like to put in a different number of hooks. So you can see now the pupil is dilated. We've got the viscoelastic, you just break the last few adhesions just to get them out of the way, and the view's better and it's safer to do the cataract operation. Because of the nature of the disease, the red reflex that we normally require to visualize the capsule is quite poor. So we use a staining mechanism with something called vision blue that's about to go in next in order to visualize the capsule better. So that's the vision blue that's gone in and been washed out. Then use a very small needle after expanding the anterior chamber again with viscoelastic to make a hole in the capsule. And then go around with the forceps to create a circular opening in the capsule. And then just to kind of, for the interest of time, ultrasound machine as standard. See the patient's now getting a little bit more comfortable. There's a tiny bit more movement from the patient, but thankfully it's all going okay. And the lens itself was quite soft, so it did come out quite nicely. And final product. So lens out, capsule intact, a bit of polishing, and then the new lens goes inside the bag. This is what the patient looked like at day 1, just to give you an idea. So obviously it was quite a traumatic operation. He's a uveitic patient, so the risk of inflammation was very high. Again, he knew very well, we counselled him beforehand that he will need regular follow-up and be seen at day 1, week 1, week 2, week 4. Thankfully he was young and fit and well. I'm very happy to come in. I saw him last week and we're now, I think, week 3, and thankfully it looks much better than this. So I'm just going to have to switch screens at the moment. The other 2 standard operations that we're still doing is essentially trabeculectomies and tube surgery to control patients' pressures. And just for people's interest, for those who haven't seen a trabeculectomy before, don't worry, I'm not going to share an hour's video. I am going to speed it up. Essentially what you're doing, it's creating a new outflow for the eye. So you're making a hole in the sclera, a kind of partial thickness flap. You go underneath it and you create a little hole. So you create the little pocket for which the fluid is going to go through. We use mitomycin C, so that's the other bits of challenging of getting stuff. So mitomycin C is an anti-cancer drug, and essentially it's got a very short viability time of 72 hours. So we have to order the stuff and use it within that time. And without it, the trabeculectomy tends to fail and scar down. So that's the mitomycin C that had gone in and then essentially gets washed out. This is the beautiful pocket. And then you're marking where you're making the cut in the sclera. Like I said, it's a partial thickness flap, go all the way up to the cornea. And then you make a little, what we use the Morpheus safe surgery technique. So these are releasable sutures that you can pull out later on if the pressure in the eye is higher than desirable. And then you enter the eye, make a little hole, cut a bit of iris up, and then sew it up. But leave the door, why I always tell people, ajar as opposed to completely closed, so you have a bit of flow at the same time, so the pressure is low, normally at day 1. Now these patients need intensive steroids post-op, so they have to go on drops every 2 hours. They need to be seen day 1 ideally, and then week 1, week 2, week 4. There's quite a bit of manipulation that happens at the beginning, so that is that one. But like I said, it does require dedication from the patient as well as the surgeon to undergo the surgery. Just a quick glimpse of trabeculectomy operation, tube operations for those who haven't witnessed it before. So essentially this is a plastic tube that goes inside the eye to allow, again, drainage, so it's creating an outflow. And for some patients, trabeculectomy is simply not an option, and we use tube surgery. It's big and bulky. This tube plate that you'll see going in a minute is about 35 millimeters in size. You have to sling the muscles, so it tends to be quite painful if done under local anesthetic. The patient tends to either need sedation or a complete general anesthesia. This patient opted for a sedation because of the risk of a general anesthetic. And thankfully all went well. So that's just the muscles being slung, and just to show you, that's the plate of the tube going in, and that's the tube that will enter the anterior chamber there. So those are kind of like the big operations, and they are all still happening. And like I said, we're quite lucky to still be able to offer our patients these surgeries where required. I go back to my point about using smaller operations. So this is an endocyclophotocoagulation. So it's lasering the ciliary body to lower the pressure by essentially turning off the tab. So if you can imagine, in glaucoma, it's quite simple. It's either you're turning off the tab, so you're not making too much aqueous fluid to reduce the pressure, or increasing the outflow by the surgeries that I've shown earlier. This is quite safe. It can be done at the end of cataract surgery and doesn't take more than 10 minutes. It is inflammatory, so we do need to see the patient probably at week 1 as opposed to day 1. Now, a lot more recently, what we have been doing is a micropulse diode laser, which is safer and a different modality than the standard cyclophotocoagulation laser. It's quite gentle, it's quite good. The laser treatment itself takes about 90 seconds, so it can be done very quickly under local anesthetic. It's quite effective. We've got about a year's worth of data now, and in about 75% of the patients, the laser does work in lowering the pressure. So that's the laser being applied to the outside of the eye. Patient can have bilateral treatments if required. They don't need to be seen at week 1. And then really for quite a lot of our patients in the current climate, we're offering them this unless we think it's not going to work, because essentially it's better for everybody. And also it's better in terms of theatre utilisation because you can treat more than one patient or more patients as such. Now, again, for those who are squeamish, you might want to look away from the screen now. This is just quite a marked trauma case that we had to repair recently. If you just look at the time, I've just taken some snapshots here. The surgery took about 2 hours to complete. This is what it looked like at the beginning, something resembling an eye. That's possibly the cornea just there with the anterior chamber full of heme. We know there's a break in the sclera with tissue hanging out. Now, the first rule of thumb of repairing any kind of trauma is being very respectful to the tissue. Obviously, this was also done under general anaesthetic because we knew it was going to take quite some time. At about half an hour, we've managed to close the scleral wound that we could see and salvage some of that tissue, starting to look more and more like an eye. Believe it or not, here it's starting to come more together. The wounds have been closed and we're slowly closing any other break in the sclera that we can see. And almost at the end, the antechamber is formed. You can appreciate that is a cornea and an anterior chamber. Yes, it's full of heme. Now, it's quite important for these patients to be very aware that they are likely to have more than one surgery. This is purely just a primary repair. So moving on from that is just to talk about the access of ophthalmic emergency services within London. At the West Night at the moment, the A&E is a walk-in between 8:30 in the morning, 8:30 at night, and at Moorfields it's 24 hours walk-in A&E. I know Guy's and Tommy's are at the moment, they did have their doctors redeployed to other areas within the hospital. I'm not sure they're back yet or not, but there are contact details for ophthalmology in the big hospitals. Just be wary that it is very active triage, so any sight-threatening conditions will be seen because of reduced number of staffing, again, because of sickness and redeployment, and for patient safety, because we don't want people sitting there in waiting areas for 4 hours unnecessarily. I know there's a number of local optometrists that are also open for emergencies. I got this from the Central London CCG of the centres that are currently open and offering minor eye condition services, and I know that they are available for contacting, but again, you do need to call them before referring patients on if required. And then there is a protocol for these minor eye condition services that need to be seen. So as you can see below, it's the standard that you would expect: sudden blurred vision, severe headaches, floaters, flashing lights, loss of vision, red eyes, foreign body sensation, ocular injury. We're in direct communication with all our local optometrists and always very happy to give advice over the phone. And like I said, if we need to see the patients, very happy to do so. Now, just moving on to the college guideline with regards to specifically the glaucoma patients. So this was issued on the 27th of March on the management of patients. It's available on the website and accessible to everyone. But the interesting thing about it was talking about new glaucoma patients and how treatment can be commenced with simply a telephone or video call. You offer them the treatment and then you can organise a face-to-face a few months later. Anybody that's suspected will have to wait for a few months, and the angle closures, as you saw earlier, they do need to be seen and treated. All tertiary referrals at the moment are suspended unless deemed necessary. So again, going back, we've had a couple of hospitals that weren't able to access their normal services. We have had referrals from other places and other hospitals, and it's basically it's based on every case, and we discuss with the surgeons and see whether or not we can offer them treatment that will be suitable for that patient. Again, with the post-op, it's try and keep patients away, keep them off the ground, keep them out of hospitals, a lot of telephone consultations. I haven't done any video consultations myself. I know there are some applications out there that allow for this to happen, and only see those really urgent cases. So at the moment, it will be the emergencies for us that are walking through, main casualty, any referrals from optoms, and then essentially any post-operative patients. And the risk stratification of patients we were already all doing in terms of high, medium and low. Just it's thinking forward when we go back to resume some form of normal activity. That's kind of the order in which the patients will be seen face to face. And like we said, it talked about the listing for surgery, only operate on the patients that, interestingly, when it talks about the only eye, so I have a patient that I saw in clinic yesterday who one eye has gone blind from an ischemic event, and now he has a white cataract in the other eye. So even though cataract surgery itself is not meant to be on the list of sight-saving surgery, but for this patient, he will be undergoing surgery on hopefully Monday to try and give him some sight back. There is a new guideline that was published late last week, talking about the general principles of how to manage ophthalmology department as a whole, not just for glaucoma, and trying to avoid face-to-face as much as possible for the accident and emergency departments to remain open. There has been a big push from us within Imperial, and I know across the country, to regain having our trainees back and having more doctors on the ground to man A&E, and it is getting busier and busier, and any kind of screening, including diabetic retinopathies, to be put on hold and consider the high risk patients. So what would the recovery phase look like? I think everybody is probably now aware and accepting of the fact that social distancing is here to remain for some time, which means that we will have to adapt our clinical settings and management of patients, both in clinic and theatres, according to that. So minimize the number of people on the ground, so moving more and more towards virtual clinics, video consultations, etc., and rely more on our local optometry colleagues and stronger links with or allied healthcare professionals to help the hospitals and just generally ophthalmologists cope with the pressures that are likely to come back and the backlog of the work. And explore new treatment options. The only other thing that I wanted to mention with regards to the glaucoma patients, there's been a question about the visual field machine sterilizing and cleaning. I know there's a lot of advice that we can't use the alcohol wipes on it because it actually ruins the machine itself. So we'll be looking at different ways of being able to assess the patient's visual fields, or maybe reducing the number of patients that require visual fields and allowing an airtime exchange between each patient, which can take anything between 20 minutes to an hour. Consider things like drug releasing implants that I know are already on the market, so again, reduce patients' visits, etc. And new operations, so smaller surgery, MIGS again, so minimally invasive glaucoma surgery in form of eye stents, and other operations, reduce surgical time, and again, post-op follow-up. And just looking at some useful links. I know there's lots and lots of information out there, but obviously the Royal College of Ophthalmologists and the Royal College of Optometrists have dedicated COVID-19 links that get updated all the time. It's probably useful just to keep a look on these things every now and again, see if there's been any changes. And I think I've reached the end of my talk. Oh, one more thing. The Ophthalmic Consultants of London have set up an eye-to-eye group, WhatsApp group. The first group has been very popular and filled, so now there's a new group. So I'm just providing the barcode for that. And lastly, thank you everybody for listening today from all of us. I know the rest of my colleagues, with the exception of Mr. Barsam, have had the pleasure of speaking to you over the last few weeks. We are all here and happy to help in any way that we can. So I look forward to answering your questions. Thank you very much.
Thanks very much, Sally. If you could just share your screen when you're ready, that would be great. And we can start with the questions. We've had a fair few questions. You did briefly mention the Humphreys visual fields that you can't use in the hospital anymore. So I've had a couple of optometrists asking, well, as we go back to routine practice and if we see these patients, what are we meant to do with regards to visual fields?
Yeah, That's $1 million question that no one has an answer for, to be honest. So for instance, we had the infection control people come and have a look at the machines yesterday. Now, I guess at local optometrists, there's not an issue of having too many people in the room at the same time. In some practices, they may have more than one visual field in the same room at the same time. So that, for instance, will not be possible because you won't be able to keep the 2-meter distance unless you have a very large room. And then the advice is you'll probably, if you do need to do a visual field, you will need to leave at least 20 minutes to an hour between patients for the air to move around if there's any droplets. And in terms of the cleaning, the advice is still warm cloth simply just warm water as opposed to using any soap or anything else. So we've been looking at the option of possibly putting a shield up. I know that might obscure the view and might interfere with the visual field. I think this is still in its infant stage. There is an option of another machine called the Octopus. I don't know if anyone's heard about it. It's an American one, and at the moment they're on rental value, and actually the patient gets to wear them as goggles. They're very clever and really good, and actually just moving forward I think they're quite good because we all have lots of patients that can't even sit on the Humphreys visual fields in the first place. So that's why I said there's a silver lining. All this is making us all rethink of how we deliver our service. So we might find that actually in a few years time the Humphreys may not be the option to go for when we're doing visual fields. I think for the time being, all glaucoma consultants are very happy to assess patients based on clinical examination and optic disc imaging. If desperate to have a visual field, I think is to have a discussion with the patient themselves with regards to possibly the risk of coming in contact with droplets, but you would have done your best for that not to happen, and also reduce flow, so only the really main cases would get a visual field as opposed to everybody that walks through the door.
Thank you, Sally. Do you think in future we're going to be relying more on OCTs in terms of monitoring progression?
Yeah, I think so. I mean, the thing with visual fields, it's very interesting. The ones that do them properly, it's amazing. So when the visual field is done properly and, there's no false positive, no false negative, it's a very, very useful tool. But, probably about 30 to 40% of the time, that's not the case, either because there's a learning curve or because the patients themselves are elderly or they have other comorbidities and, like I said, are unable to get onto the visual fields, whether the instructions that they get given to use the visual field machine in the first place are not clear. So it's never the end all and be all. And I'm sure we've all been in situations where you do a visual field because it's part of the NICE guidelines of diagnosing glaucoma patients, and you look at it and you think, well, that was completely useless. We are moving more and more towards objective ways of assessing patients, and the OCT is definitely a lot more objective, and I know they are looking at modules of mapping out what they think the visual field defect would look like based on the disc changes. So that will be a very interesting and exciting new thing moving forward. And then again, you just put them on the machine, they have the scan, it takes no longer than 30 seconds, and then it can map out what it thinks its visual field defect might be. Once we get more data and that gets done more frequently, it will probably come more mainstream.
Thank you, Sally. In the realms of technology, how about measuring IOPs? A lot of practices still have, we use a non-contact thermometer, so things like the pulse air, which can be aerosol generating.
Yeah, it's interesting actually. So we did think about that. So I obviously use the Goldman, and I know lots of places use the iCare. Yeah. It's a hard one. In theory, it could be, but again, if you think about it, it's a very small distance. It's a very small amount. The coronavirus or the COVID-19 is a heavy virus, so we know if anything, it settles on heavier surfaces and lower down as opposed to closer to the eye. And even in the patients who've been proven COVID-19 positive, the presence of the virus within their secretions in the mucosa, around the eye and their tears is very, very, very minimal. There is still a risk, but it's very small. So it's whether or not, again, this is a time to reconsider using other modalities of assessing IOP. I think what this situation has thrown is making everyone think outside the box, so not continue practice as normal. I think the new normal is going to be completely different from what we know it as. There's going to be an opportunity to utilize on this and essentially look at new technologies and new ways of doing it, and maybe again the use of the Puffer assessment of IOP may be obsolete, at least for the time being.
Okay, and just before I move on from technology, we do have someone that's saying they're a little bit confused. In terms of visual field in routine practice, are you saying that with most of the machines that clinics have, is that this, we just won't be doing this now?
Basically.
Okay, thank you. We have a few questions regarding glaucoma in general, and one of them is, are you seeing a lot more glaucoma due to ICLs?
ICLs.
The implantable polymer lenses, is it causing a lot more glaucoma?
Oh, no, actually. No, that's an important one to answer. Not really.
Great, thank you. Something about COVID-19 and the patients that are on Diamox, I don't know whether you have...
I have quite a few.
Yes, are they less susceptible to getting bad symptoms of COVID-19? Someone's asking because it's a carbonic anhydrase inhibitor.
Funny that, I think the few that I have had, thankfully, they tend to be young and well, even though we know COVID-19 does affect the young as well, but it doesn't seem to have caused any increased risk of, you know, getting COVID-19 or becoming symptomatic.
Okay, thanks, Sally. Someone is asking, with regards to morphils in the Western eye, are they seeing anybody who turns up? And that, to be fair, I've had a few patients ask as well, that they're being advised to go to their nearest hospital and they can't just walk in because they're having a triage centre. So if you could...
Yes, so to tell you what's happening on the ground at the Western Eye, I think it's the same at Moorfields Eye Hospital. Essentially, it is active triage, but everybody that does come in, any patient that does come in, does get seen either by a nurse practitioner or a doctor, does have their visual acuity checked, does have their eye pressure checked to reassure the patient, and will be given advice. So they will not just be simply turned away at the door. So what happens is, if we have nurse practitioners, they do the active triaging. So for instance, the patient comes in, they have a red eye, we assess their visual acuity is fine, pressure is fine, and it looks like a conjunctivitis, then we give them the conjunctivitis advice and, you know, ask them to, you know, leave with that advice. And if they don't get better, to give them a contact telephone number to call us back or arrange for them to come back for follow-up. So that's what active triaging mean. It's not that you just get turned away at the door. And again, don't forget, there's been a lot of publicity recently on the BBC website and from the government to say, if you need medical advice, to seek it. So we have definitely, over the last 1 to 2 weeks, seen an increase in number of patients attending A&E, which is why I was saying we're trying to get more people back down on the ground, so we can, as doctors and health care professionals, see more of these people, as opposed to just have them have the assessment and go away. But like I said, they will have an assessment, not just simply get told, no, you can't come in. So they will see everyone, triage them, and the ones that require to be physically seen and assessed will then be seen.
Thanks, Sally. With regards to IOP, in terms of the eye care, Goldman, Perkins, that's okay for us to use in clinic?
Yeah, that's fine.
Okay, thank you. And also, in terms of, if we're not doing certain tests, like the visual fields, for example, is it quite sufficient for us to write in our notes, visual fields not done, and
yeah,
that's enough?
Absolutely. I think, so again, for instance, with the telephone consultations now, the first entry when we do the electronic patient records is we enter COVID-19 protocol. So I think that's one thing. So if anybody ever goes back and there's questions that gets raised why this patient didn't have X, Y, and Z, as you would expect, you know, they'll be able to tell from the date of the visit. But I think simply just put in COVID-19 protocol, then everybody would understand why certain tests weren't being done.
If in practice, if we find an incidental finding of glaucoma when we can receive something else, it's not an emergency, what do we do?
Yeah, so this again, which is why the Royal College guideline about glaucoma treatment is very good. So they are now saying you start treatment, obviously, as many optometrists you won't be able to do so. So there are points of contact, which, like I said, at the Western and at Moorfields and most local eye units, there are still doctors physically on the ground. So it's simply contacting your local eye unit, and if you can't access them, you can contact the central ones and just get advice over the phone. Say, this is what I found, this is the pressure, everything else looks okay. Would you be happy to prescribe this patient a medication, and generate a letter to the GP? And we have done that a couple of times, and it's quite well.
Oh, right, okay, thanks. That's very interesting. Do you think in the future there's going to be more links between ophthalmology and optometrists in terms of...
I hope so. Yeah, I hope so. I think, to be honest, it's vital, and I think it was long overdue and long needed. I mean, we all pretty much treat most of it. We have so many shared patients, and a lot of that data, especially, like I said, with the electronic patient records, can be shared across sites, and images get moved around. You don't physically need to see quite a lot of these patients, so you can have someone email you on a safe link or another form of communication, like this is this patient OCT visual field, if you can get it, these are the pressure measurements, what's your feeling, and take it from there.
Thanks, Sally. In terms of yourself and OCL, are you going to start seeing referrals in from optometrists, even if they're just routine glaucoma cases?
So that's quite interesting. I've seen a couple. It's interesting if you want to say routine. It's questioned about whether or not the patient has moderate to severe glaucoma, so I felt that it was safe. And I think I normally call the patient beforehand and assess their general risk of travel, how easy it is for them to get to me at the many sites of OCL, and whether or not they wish to be seen, because sometimes the patients don't want to be seen, and how much I can offer them. So maybe, like I said, some of the stuff can be offered over the phone. So if it's simply someone who already has glaucoma but are not happy about the drops that they're taking, we can discuss over the phone the option of using different drops and then revisiting again when the situation is safer and examining the patient in person. So it's kind of case by case. Like we talked about in terms of spacing in the clinics, it's a matter of if the patient does need to come in, it's ensuring that not too many patients are all coming in at the same time. The tests that need to get done will get done swiftly, they get seen very quickly, and get them in and out of the door as quickly as we can.
Thank you, Sally. Back to the optometry practice. So for screening for patients, let's say we do suspect glaucoma but we're not quite sure, is it justifiable to see them every 6 months rather than every year, and just if we're just doing an eye care and an OCT?
I think for now, yes. I think that especially because you haven't got the visual field back up, and the likelihood of them being seen in clinic is going to be quite some time. So yeah, seeing them at 6 months is fine. And then hopefully what would be interesting is getting data and auditing all this information that's coming through. So maybe seeing, well, actually I've seen them every 6 months as opposed to a year. Has that really changed my management plan? And if the answer is yes, then you know actually that's the way to go forward. Whereas if the answer is no, then you can revert back to your original practice of seeing patients every 12 months and feel safe that actually you are practicing safe care to your patients.
Thanks. In terms of back to the visual fields, but are there any visual fields that optometrists can use?
Not that I know of. Are there any other visual fields that you guys have?
Don't have the bowl. So in terms of cleaning, you can clean the machine.
Can you clean it with alcohol wipes? There's something about the alcohol wipe that does something to the machine. That's the only thing. Right. I think if you in your practice have a machine that is deemed safe to use and can be sterilized and cleaned appropriately, then yes, absolutely fine. But then just be wary that the data that you'll be producing may not be that useful anyway, because it's not something that is recognized either by the doctor that you're going to refer it onto. So because most of us are used to just using the Humphreys, or may not, like I said, affect the management ultimately that much regardless. What would be interesting is what the DVLA are going to do with regards to the visual field test for driving.
That's an interesting point. We are getting a lot of questions about the visual fields, and regarding the mask, I know it's all to do with the cleaning, but even the patient wearing a mask, you can't just have patients wearing masks and then using that same machine.
So like I said, I mean, this is why we had the infection control people come in yesterday. This is what we thought. We thought the patient wears a mask, operator wears a mask, everything gets cleaned, you give it about 20 minutes in between, and hopefully it'll be all right. In theory, yes, but it's the nature of the disease, I think. It's, because COVID-19 essentially is a silent disease. You don't know who has it or who hasn't got it. A lot of people might be asymptomatic. They come in and you just need one person to cough on that machine that has COVID-19 and then somebody else to contract it, and then all the machines get closed up. That is the problem with this. Again, because we are going into uncharted territory, everyone is erring on the side of caution. So they're saying, well, if right now, if you can live without the visual field, then try and live without the visual field. Again, the advice is continuously changing, like with the PPE, like with the surgery, like with the treatments. We may find actually the college might release some guideline about this anyway in a few weeks' time about, using visual fields in patients and who to do it on. And then it'll be clearer, and then everybody will feel slightly safer. We'll say, well, this is the guideline. They said we shouldn't do it on everybody, and that's fine.
Thanks, Sally. A couple of questions clinically about glaucoma, if that's okay.
Oh.
Is it okay to use prostaglandin medications in patients with a history of herpetic uveitis? And are contraindicated for beta blockers?
Right. So the simple answer is yes. I think obviously there's a lot of theoretical risks with these drops. Some of them are probably, founded because of previous evidence of them exacerbating things like hepatic ulcers. Again, like we know with patients who have diabetes and diabetic macular edema, in patients who have inflammatory disease like uveitis, theoretically prostaglandin analogs exacerbate those conditions. But again, I think you have to treat every case as it comes, and the risk is very, very small. Versus using a beta blocker where it's contraindicated, we know the risk of that causing a complication is quite real, and the patient's becoming symptomatic with shortness of breath. With the eye stuff and the use of prostaglandin, I tend to advise the patients, if I know, I will say there is a theoretical risk of this happening, and these would be the symptoms. So for instance, in the diabetic patients, worsening vision because of the macular edema, in the uveitis, recurrence of the uveitis, and most of them are very used to their own symptoms. And in the hepatics, again, it will be the recurrence of their symptoms. So I think it's definitely worth trying. And then if it doesn't work, or it does exacerbate their pre-existing condition, then you'll have to go back to your thinking board and think of an alternative.
Thank you, Sally. A question on the difference between when you do tube surgery and when you do a trabeculectomy. Could you give us a brief summary? I know it's probably a topic in itself.
No, that's fine. So for me, my trabeculectomy is the go-to filtration surgery as option one. A couple of reasons for that. I like it as an operation. It works beautifully well. Success rate is about 95% of being drop-free, and that's the interesting point about it. With tube surgery, about 50% of patients still require to use glaucoma drops afterwards. Saying that, there are certain conditions where you know almost definitely the trabeculectomy is going to fail, and that is mainly related to the patient and the eye itself. So an inflamed eye, so some people say if you've had severe uveitis or ongoing uveitis where you're pro-inflammatory, you go into one to scar down. So it's just understanding the mechanism of how it works. So with the trabeculectomy, you're creating a flap door that you want to stay open, that naturally the body is going to want to heal. Whereas with the tube, you're putting a plastic implant that's going to remain open. So if you think they are at higher risk of scarring because of, for instance, like I said, uveitis, previous trauma, retinal surgery, definitely because they go through the conjunctiva and they cause a lot of scarring. Younger patients, so historically trabeculectomies last about 10 to 15 years. So if you think your patient's only in their 30s and needing to undergo surgery, maybe consider tube surgery because it might last longer. But again, for me, that's kind of like a weak one. It's really if I think the surgery itself is going to fail. And then also you can always, if God forbid the trab fails, go and perform a tube operation. If the tube fails, you can't go back and do a trabeculectomy because the tissues have already been scarred and damaged, and almost definitely the trabeculectomy will fail. So basically my stepwise treatment regime is drops, obviously, laser where possible, combined with, if they need a cataract operation, and MIGS if it's an option, so lots of MIGS comes in. But if they've got advanced disease that's progressing very aggressively, then trabeculectomy first, unless there is an obvious contraindication for it, and God forbid, tube afterwards.
Thank you, Sally. Which of these are you currently offering at OCL? We have a question. Which of these are you doing at OCL?
I think all of them. They are all available at OCL.
Perfect, thank you. A couple of questions on an OCT. We do have a few minutes left if you're okay, Sally. Sure. Any tips on how, if we're not doing a visual fields, if we're just looking at OCT, how we can accurately diagnose glaucoma or monitor progression? Any tips that you could give us?
So obviously there is a progressor analysis on the OCT machine, especially in patients that you have scanned more than once. So it shows you the progression analysis. So that's obviously a very easy, good one. And if you ever, I'm trying to see if I have an OCT on here, I don't. On the right-hand corner, there's a button that has the different areas, and you can press on the different arrows and it shows you which area of the optic nerve head is progressing more than others, which might be quite interesting because the first image shows you a global picture, and the graph of the progression shows you a global progression. So it may look like it's, for instance, static, but then if you press on every single segment, you might notice that actually one segment is progressing more than others. And also there are the backwards and forward arrows that you can press on the in between images to compare images if you're not looking at the progressor analysis, and look at the numbers of the thickness of the retinal fiber layer and see the change and progression that way. So that's another way of assessing it.
Thank you. Another question on trabeculectomies is, why does it work? Why doesn't everybody heal and scar over? And also, is there a new drug?
Operation.
Is there a new drug, Deckering, that's being used?
I don't know about that one. So why does it work? Honestly, when I first started in ophthalmology, I thought trabeculectomy is the craziest operation in the world. You're making a hole and then you're closing it up. Well, how that makes any sense is beyond me. But it is literally an art. It's well, the tissue has to be handled very delicately. You have to make very minimal trauma to the eye. And essentially, you just create this flap door. And if you remember going back to the video, if you cast your mind back, these little loops that we create in the flap that essentially just hold the door just a little bit open. And that allows aqueous fluid to come out. Now, that is vital because what it does, that separates the tissues and prevents scarring. So that's why I said flow on the table is very important. So the steroids, which is why they have to be very intensive at the beginning, which is every 2 hours, they reduce the risk of scarring. The regular visits, we keep monitoring these patients. Say if we notice that the pressure is going up, or actually when you look at it and examining it, it looks like it's scarring. The trabeculectomy bleb is flattening down, so there is no flow. We manipulate the bleb, so that's when we take out these releasable sutures, and that can be done in clinic and opens that door even more to allow more fluid to come out to prevent any scarring. And we give anti-scarring injections into the eye, so that's dexamethasone, steroids, and 5-fluorouracil, which is another drug that halts cell regeneration. Remember I talked about mitomycin C, so that's been vital at making trabeculectomies work because essentially this stops the cell cycle in the S phase permanently, so it prevents any kind of tissue healing as such, but then you have to use it very cautiously because you want some healing, otherwise the whole thing will leak. So that's why you have to and use it for about 2-3 minutes and then wash it out of the eye afterwards. You don't keep it any longer from that, otherwise you do get tissue ischemia. So I think it's the technique itself is developed over the years. The use of adjuvant drugs like mitomycin C and 5-fluorouracil, better preservative-free drops, because most of our patients, even before they undergo trabeculectomies, the tissues are healthier. They've not been impregnated with drugs and backs and, making the conj rubber hard. So the success rate has been definitely better since the introduction of the preservative-free drops. And I think, again, we all tweak our techniques ever so slightly. I don't think 2 surgeons in the country would tell you they do the trabeculectomy the same. It's whatever's comfortable in people's hands.
Thanks, Sally. There are a few questions about Deckering as a future drug, but someone has just mentioned it's in its phase 1 of clinical trials, which is that's why it's not out there yet. A few people have said that they've had patients from the Far East who had peripheral iridectomies done as routine if there is a family history of glaucoma.
That's interesting. Yeah, well, we definitely got to do that here. Actually, we were discussing this just beforehand. So the practice that was done when patients get referred to us with narrow angles, query angle closure is depending on the patient's age and depending on what they wish to have. So everybody, I'm sure, is aware of the EAGLE trial that looked at clear lens extraction in patients with primary angle closure that have raised pressure but are otherwise completely asymptomatic versus peripheral iridotomy, and it showed that long-term clear lens extraction is a more superior treatment option because essentially you are curing the condition. What you're doing is you're taking a big bulky lens out, putting a slim plastic lens in and opening the drainage angle straight away. So that is the only form of glaucoma that we can really cure. So what was happening before this whole COVID-19 situation when patients got referred to me, I tend to discuss with them, these are the options. We do nothing because, lots of studies recently looked at the natural history of progression of treating one eye and watching the other eye, and actually in about 70% of the time, over 5 years, nothing happened to the patients in the untreated eye. So, they have a 70% chance of remaining completely asymptomatic versus having a peripheral iridotomy, more so for the younger patients if they need it. So if on examination the angle is definitely closed, then you'd offer a peripheral iridotomy. But anybody over the age of 50, 55, then I'd probably you know, encourage them to consider a clear lens extraction. The reason for that is, even if you have a patent peripheral iridotomy, after a while that lens keeps on growing, and then you'll find, you know, that the laser works by redirecting the fluid and pushing the iris diaphragm away from the angle. But if you have a big lens that's in the way, it can't physically do that. So what they might find is they have the peripheral iridotomy, and then 6 to 12 months later they get examined and get told the angle's closed and they need something else. So for those patients, I'd probably encourage them more to have clear lens extraction. Now, whether doing it prophylactically in patients just because their relatives have it is a very interesting thing. You would have to treat that patient, not their relative. I wouldn't offer treatment to someone just because their relative might have had it.
And PIs aren't being phased out, you still do them?
No, still there. Sorry, it takes me back to the point. So with COVID-19 again, probably speak to people about maybe having a PI, because that will buy them the 6 to 12 months until we know what's happening, versus having a clear lens extraction. Now, it won't be offered right now because it's not deemed emergency surgery if they are asymptomatic and their pressure's fine. So the PI will be a safe option right now, definitely.
Thanks. I'm going to ask you one more question since we do have time. Is your views on SLT?
I like SLT. It's good. It works. The light trial that I'm sure Gus Gardner did, that everybody knows about, was really good at looking at the efficacy of SLT. Essentially, it's one of those things that you treat the patient and you're not quite sure if anything's happened or nothing's happened. The theory behind it, it just generates a kind of a sub-threshold level of inflammation, gets the macrophages to come in and eat up any debris that's sitting in the trabecular meshwork and the drainage angle, and that's how the pressure comes down. It definitely does work. It works in about 75 to 80% of patients. And the beauty of it is the safety profile. It is quite safe, with the exception of a few cases that we know are at predisposition of getting high pressure after the SLT, like pigment dispersion syndrome, and I'll discuss why that will happen. You know, the pressure spike, even if it does happen, tends to be transient for a few hours and then it goes back to normal again. So the worst that can happen is they undergo this laser treatment and it doesn't work, and then they would have to use drops. We know it works better on virgin eyes. We know it works better on eyes that have had any other glaucoma drops than prostaglandins. The prostaglandins seem to do something to the actual trabecular meshwork structure over time, possibly make it more rigid and therefore the laser less effective. So if we are considering doing this treatment, it's better to do it sooner rather than later. So just going back to the pigment dispersion. So if you just remember what I said about how it works, so it does cause a bit of disruption, and with the pigment dispersion, you've mechanically got these clumps of pigment sitting in the angle. So as the laser hits them, you can see them flying off everywhere, and they can cause a bit of a storm. And as that happens, they can get an IOP rise. Now, I've been doing glaucoma for about 8 years, and I think in that time I've only had one patient that had sustained IOP rise post SLT, and I do a weekly SLT laser clinic, and they were pigment dispersion patients. So for those patients, you have to treat them cautiously. You only treat 180 degrees of the angle as opposed to 360 as you would do with everybody else. And if you're seeing too much reaction with the laser, turn the laser energy down as much as possible, and just you know, again, you can stop if you, even at the lowest level, still seeing too much reaction. You simply cease the treatment and maybe treat one eye instead of both eyes in the same sitting, just to see how the first eye behaves before treating the other eye.
Sally, thank you so much. I am just going to launch the poll, if that's okay. If anybody can just fill in that poll whilst we have a little more of a chat, that would be useful. Thanks very much. If there are any other topics that you would like Sally to cover, then please do just write it in the Q&A box. Anything specific to glaucoma or visual fields, or anything really that you'd like to discuss, and that would be great. We'll follow that up in the future. And Sally, finally, can you please discuss that trauma case? What had happened to that poor eye?
It was actually a very sad trauma case. The patient was a paramedic, which is obviously just makes it even more awful, and essentially was attending to a patient, and I think in the kerfuffle of everything walked into a broken sign on their street lamp. So literally the jagged edge went straight into the eye, and that's why it was like it was a bit of a mess, and the wound was a very dirty wound. And like I said, in those cases, the first thing that you say is, you know, this is a primary repair, and it's all about managing patients' expectations. It's about a matter of, we are trying to put the eye together. almost definitely he's going to need a second, third, fourth operation, and the eyesight is going to be very limited in that eye. Interestingly, we are seeing more and more trauma cases. Lots of people are doing lots of DIY, lots of things flying into their eyes. So please, if you are doing more DIY in the house and the garden, wear protective goggles. You do not want to be in any hospital, let alone an eye hospital right now. Yeah, it's a slightly sad story.
Thank you so much, and thank you to everyone who has responded to that poll. And that's what we've got time for today. Sally, thank you so much. It's been a fantastic webinar. So our next one is tomorrow, and that is with Mr. Alan Barsam. I know he's very excited to present tomorrow. So the registration link for that is found on Facebook or our Insta page, or on the WhatsApp group if you are on there. So please do log in. It's going to be another fantastic webinar. And thank you very much, everybody. Have a great bank holiday. It is a bank holiday on Friday, but I'll see you tomorrow. And have a great evening. Thanks very much. Bye-bye.
Bye.